Hello and welcome. My name is Lisa Workman and I'm an exercise specialist with the Edmonton Southside Primary Care Network. This is your first of two educational sessions for the GLA Canada's Knee and Hip program. The GLAD Canada program is happy to have you here. We are going to cover two education sessions regarding your osteoarthritis and ways to help you manage your condition. This again is the first of the two education sessions. So be sure to watch this video first, followed by the second educational video. We are also going to be providing specific neuromuscular exercises for both your hips and your knees, with the goal to help improve your joint function. This will happen with supervised exercise sessions over a 12 sessions, and it'll come over about 6 to 7 weeks. The supervision will be supplied by myself or another one of my team members. We are all clinical exercise physiologists. So our objectives in the GLAD Canada program are to provide an opportunity for you to understand your osteoarthritis. We're going to look at the risk factors or why people get osteoarthritis. We're going to discuss possible symptoms and treatment, as well as provide some tips and hints about ways to help self-manage or self-help yourself with your osteoarthritis. The goal of the GLAD Canada program is to help you reduce your levels of pain and hopefully improve the quality of your life. So in this first session, we will be covering specifically what is osteoarthritis and go through specific details to provide maybe a context as to how your joint is built and how it functions. We will also be talking about risk factors, symptoms of osteoarthritis, and a brief summary of possible treatments. In the second session, we will go into more detail about the treatment options, as well as those tips and hints about self-management for your condition. At any point in time, you are welcome to hit pause on this presentation to do a little bit of movement or stand up. Don't feel like you have to stay seated for the duration of this presentation. So let's jump in. Let's go into what is osteoarthritis. Osteoarthritis is a disease that affects the whole entire joint. And this is a condition related to somewhat a thinning or a breakdown of the cartilage that is on the two ends of the connecting bones. Osteoarthritis can start without any obvious reason why, and it is the leading cause for people 65 years and older not to be physically active. Osteoarthritis has been presented as a wear and tear disease. And when we think of osteoarthritis as a wear and tear disease, that also makes us think that we shouldn't do any sort of movement or extra physical activity and exercise because it'll progress that wear and tear in that joint. Now what we know is it's not a wear and tear disease, and that physical activity and exercise is actually the best thing that you can do for your joint health. Rather, osteoarthritis is joint failure. So the joint is no longer functioning as it once did, and thus osteoarthritis starts to begin. So we'll go into greater detail how that sort of works or how that is laid out, but trying to reframe how you think about osteoarthritis. It is not a wear and tear disease. It is more about joint failure. So osteoarthritis is actually very, very common. It is more common than high blood pressure and diabetes. It is the most common lifestyle disease in people older than 65 years. And it's not just for individuals that are over the age of 65. Knee and hip pain are very common, particularly in people age 50 and above. About 30% of people age 50 and above will report some hip or knee pain. And maybe surprisingly, people between the ages of 35 and 55 also can experience osteoarthritis, and it's actually demonstrated in imaging on x-rays, so about 5% of that age bracket. So osteoarthritis doesn't simply relate to an older age. It can be as early as in your 30s that you have osteoarthritis. And then when looking at osteoarthritis in the population, you do see an increase over time of osteoarthritis as we age. But what we have to remember is that osteoarthritis is joint dysfunction. And so if your joint starts to not function properly in your 30s, then the chance of that osteoarthritis being greater as you age makes sense. You've been using a joint incorrectly, or it's been aligned the wrong way, or it's just not functioning the way it should. That over time is going to result in potentially osteoarthritis and a condition of dysfunction. So it's not that age causes osteoarthritis. It's that if that joint begins to function not very well, then as you age, it's going to intensify, and the likelihood of osteoarthritis is much greater. Although we are here to talk about knee and hip osteoarthritis, we do see that hand osteoarthritis is quite significant on this diagram. We see quite a sharp increase of hand osteoarthritis around the age of 60. So we will address it briefly in this presentation, but the GLAD Canada program is specifically for exercises and assistance with knee and hip osteoarthritis. As well as you can see that there's a higher proportion of people in our population that will experience knee osteoarthritis rather than hip osteoarthritis. You can see the difference there between the green and the black line. So again, it's not that age is causing osteoarthritis. It is having a dysfunctional joint that's not working over many, many years, and that's where osteoarthritis might begin to show up. The other interesting fact about this slide is that there is a fairly strong relationship between those people who have knee osteoarthritis and hand osteoarthritis. Those sometimes are ones that go together. So if you have knee osteoarthritis, you might also have hand osteoarthritis as well. And so we'll move into a little bit of the anatomy. And so the tissue that we are very interested in with our osteoarthritis is what's called articular cartilage. And that tissue is at the end of two bones as they meet. So as you see in the image on the left, we've got this white sort of lining on both sides of the bones. That is actually articular cartilage. It is smooth. It's on the ends of the bones to allow for a smooth surface. So the bones are able to slide and glide much easier. Cartilage also absorbs shock and distributes load or pressure. So every time you set your foot down on the ground, that is an equal force that's going to come back to the joint from the ground. So it's able to sort of absorb some of that pressure or load. Cartilage does not have a nerve supply and nor a blood supply. And so the way that cartilage gets nourishment is through what's called synovial fluid. And synovial fluid, we'll talk about shortly, is the yellow space in between those two bones. So as we move our bodies and contract the muscles around our joint, that fluid increases around that joint capsule. So if you look at that picture on the left, you're going to see a fibrous articular capsule as well as a synovial articular capsule. And don't worry about the details of the names, but that capsule is what encases those two bones in the joint and is able to keep that fluid inside that space to help with that slide and glide, and most importantly, keeping that cartilage healthy. So surprisingly, that is actually a demonstration or an illustration of our knee joint. Now you can see the image up in the top right corner, the exact same image. So we've got the long bone on the top, which is our femur, and the shorter bone underneath is our tibia, our lower shin bone. And those two bones come together to form the knee joint. Now, of course, there is no kneecap there or patella in that rudimentary drawing. You can see that in the more anatomy-based image below, you'll see the patella. But again, this is for demonstration purposes to show you the parts of your joint, particularly the knee joint. So we've got that cartilage on the ends of the two bones, like I've talked already. And osteoarthritis is the wearing away or the thinning of that cartilage that then doesn't allow those bones to move and glide nicely together. In the knee joint, we also have meniscus or menisci. So we've got these little pillows, I like to call them, that sit between the top of the lower leg bone, and then the higher leg bone is sitting on top. So you'll see the meniscus in the anatomy picture as a blue little disc. And you can see how it sits in that knee joint to also absorb shock and allow for a nice smooth glide in that knee joint. I've alluded to already, there is that articular capsule, so that is going to be around those two bones to hold that fluid inside the joint. And then the synovial fluid or that articular fluid is what is then released when we move our bodies. So there is a beautiful physiology in our body, a mechanism that says, oh, you are moving. I need to send more lubrication. I like to think of it as some WD-40 needs to go into that joint. And when we bring that fluid to the joint, it helps us move better, but it also brings nourishment to that connective tissue of cartilage on the ends of those two bones. In our knee joint, we also have numerous ligaments as well as muscles. We won't go into greater detail on the anatomy of the muscles and ligaments, but common ligament that you might hear about might be an ACL ligament, which is an anterior cruciate ligament. You'll hear that one. You might hear MCL as well, or a PCL. These are all ligaments that help attach bone to bone and keep that joint functioning well. And then we have muscles, and of course there are lots of muscles surrounding the knee joint. Particularly, you might have heard of the quadricep muscle, the hamstring muscle, potentially a calf muscle or gastrocnemius. Again, these are all words you don't have to get too hung up on, but those are all the pieces of what makes a healthy knee joint. As we move now to the hip, there are a couple distinct differences in a hip joint versus a knee joint. A hip joint is what we would consider a ball and socket joint. So the head of your femur is rounded off like a ball, and it sits into what we call a fossa, an acetabulum fossa, if you want to get really detailed, but basically a concave part of our pelvis, and the head of the femur is a convex part of the bone. So they go together nicely as a ball and socket. Whereas the knee joint previously is considered a hinge joint. So it only really moves in one direction, whereas a ball and socket has a lot more mobility as it can move around and do more circular motions. So of course here in our hip joint we have cartilage. We've got cartilage, the white coloring on the top of the femur, as well as within that fossa we see a lining of sort of white tissue there. That is our cartilage. So we do have that. We also have the articular capsule around that joint to provide that integrity and keep that synovial fluid within that joint. As well as the next point on the slide shows, we've got synovial fluid that will be released as we contract muscles around that joint. We also have a lot of ligaments and muscles that support us in our hip joint. Again, we won't go into greater detail about that. Part of the exercises that we do in the GLAD program are, of course, to stimulate these muscles, typically our gluteal muscles, our hip flexor muscles. There's a lot of muscles around the hip joint that we'll work through to help you bring fluid into that hip joint. The one major thing that is missing, as you may tell, is that there is no meniscus in there. There's no little cushion that's in between the two bones. So we don't have that inside the concave part of the pelvis. There's nothing there like a meniscus. So that is unique to the knee joint. And as you can imagine, it's definitely for shock absorption. There's a little bit more force that's going to be transferred to the knee, and that'll dissipate as it gets to the hip. Now, of course, there will be forces put on the hip joint at all times, but it's a little different. It's not the first joint to absorb shock. The knee would probably, again, dissipate that force before it hits the hip. So when we're looking at, what specifically happens to those two healthy joints, that hip or that knee, to actually cause that osteoarthritis. And as I said earlier on, sometimes we don't even have a reason why. We don't have a specific scenario that we can, reflect back on, say, oh, that's what caused the osteoarthritis. But essentially, we're looking at an imbalance is when we start to form osteoarthritis. So, for example, here we have two individuals. We've got this hard-working man who's carrying a crate on his back, and what I like to call my 1980s aerobics participant on the right. And so let's think about this gentleman here. He's got a heavy load. He's working really hard. You can see he is perspiring. And with every movement that we do, in general, we do have some form of degeneration. So this gentleman is having some degeneration. However, he has probably decided to carry this load long term, and it is not allowing for any form of regeneration. It's a very thin regeneration. And so we cycle through degeneration and regeneration and degeneration and regeneration. And if we don't have a balance between those two with tissue breakdown and tissue growth, then we get a greater degeneration. So he's got this excess load. And sometimes I reflect on potentially some occupations that allow a lot of degeneration and possibly not a lot of regeneration. You can think of a lot of physical work type of jobs that may have a lot of overload and not a lot of time for regeneration. So think about that. Whereas our lady who's doing her 1980s aerobics class, she is able to balance. She's got degeneration, but she's not overloading herself to the point where she doesn't have time to regenerate. So she's sort of got this healthy cycle. Not to say, honestly, we could have this healthy cycle and there's other causes of osteoarthritis. But in general, when the joint is not functioning at its best and it starts to become dysfunctional, that degeneration is greater than the regeneration, then we start to anticipate that osteoarthritis might become present. So here is an image of the knee joint. You can see that potentially there is a little less white tissue, or we could see that sort of little bit of breakdown of the cartilage on that far left-hand side, potentially. We also see that joint space is really, really small in areas. So there's not a lot of space between those two bones. And so we've got potentially, if there's limited cartilage there, that there's not going to be a smooth glide and slide with that knee joint. So common things that might show up if we are presenting with osteoarthritis: we might have pain with weight bearing. We might have stiff and unstable legs. Particularly that stiffness might show up in the morning because the joint hasn't been moving all night. It's been probably quite stationary, so we have stiffness. We might have crunching or clicking noises of that joint, so movement of the bone on bone, or the ligaments and their alignment could be causing some sounds. Reduction of our range of motion, so we may not need to be able to bend our knee as well as we once did. And interestingly, the pain sites can vary. We can see the pain above the knee joint, the inner or outer part of the knee, or potentially down the lower leg. That might be where it presents itself, and it's all linked back to the osteoarthritis in the knee. One thing to note too is if there is a damage to the meniscus, then potentially that would be another progression towards osteoarthritis as well. So if we've injured a meniscus, that could also be part of the disease of osteoarthritis. Now looking at the hip and our imaging here, again, interesting enough, I think right off the hop, you can see that that ball is really quite deep into that socket. That space is very, very small and limited. Also, you might be able to see maybe areas where that cartilage is not necessarily as thick in some areas as others. So what might show up with hip osteoarthritis? We might have pain with weight bearing. So an example would be standing and chopping vegetables at your kitchen counter for a prolonged period of time. You just don't have the ability to stand there because the pain is so great. Here we have reduction in the range of motion that you can do. So that starts to affect your walking gait, climbing stairs. You may have limited range. All of these sort of activities of daily living start to become challenging. So pain could show up again in multiple different places. So interesting enough, it could be often on the outer part of the hip or deep inside your groin, inner or outer part of the thigh. And the one that's always very intriguing to me is that it's actually above or inside the knee that osteoarthritis hip pain can be. So it's so interesting where it might show up, that if you are having sensation in the knee, it might actually be being generated from the dysfunction of the hip and osteoarthritis in the hip. And like I said, we were going to touch a little bit on hand osteoarthritis, not a lot of it, but just a little bit, because many people who have knee osteoarthritis might also have osteoarthritis in their hands and their fingers. Hand osteoarthritis will affect the ends of the fingers and the base of the thumb. So that first little knuckle at the very top. So if you grab your own finger, it's the first knuckle at the top below the nail bed. That's the most common place, as well as if you grab the base of your thumb, that joint there is the most common place for it. You may feel stiff or tender, and that then can result in reduced function. So for example, grabbing a hold of a coffee mug may become problematic. You might not have the ability to grasp it as well. And then you have reduced function and the ability to be confident that you can hold a steaming hot cup of coffee in your hand. Bone ends might also look large and deformed, so you start seeing some changes in how your fingers look. There's sometimes enlargement around those joints. And then also the weakness of your hands, like alluding to the coffee cup too. Like if you have reduced function, the muscles aren't functioning properly, so they become really weak and you just can't trust your hands. Women tend to have hand osteoarthritis more so than men. And we just have to remember that osteoarthritis can occur in any joint where the ends of bones are covered in cartilage. So they typically are joints that we call synovial joints, where we have that cartilage on both ends of the bone. So it's not just simply knee and hip, it can be in any of these joints that have cartilage on the two ends of the meeting bones. All right, so we have just gone through what is osteoarthritis in quite a bit of detail, that anatomy piece. Hopefully you have a greater understanding of your two different types of joints. If at this point you want to pause the video and take a moment to get up and move, if you're not feeling like sitting this long has been good for you, go ahead and pause the video and come back shortly. So our next part of our presentation today is all about the risk factors. What are the risk factors of osteoarthritis? And so we have two different types of risk factors. We have modifiable and non-modifiable risk factors. So modifiable ones are things that you can change. We'll put those in quotations, things that you can change most likely. Because the first one, joint injury. So we would really like for people to avoid getting injured, of course, but there's some scenarios where it can be out of your control. I guess it's thinking about trying to limit situations where you could actually injure your joint. So for example, soccer players, so if they're playing a soccer game, they are in a higher risk of becoming injured. And so if you, let's say, injure your ACL, so that is your anterior cruciate ligament in your knee joint, let's say in a soccer game, you could potentially tear it or completely rupture it. You know, that is then a major joint injury. And there is a significant chance that if you injure your ACL in your knee, that you are going to develop osteoarthritis as you age. I think it's as high as 30 to 40% of cases of ACL injuries will result in osteoarthritis later in life. Because as you can imagine, that joint is no longer functioning as it once did. When that ligament has been torn or completely is not there anymore, then that knee does not move the way it used to. The other thing with our joint is overloading it. So just like the gentleman in that regeneration, degeneration slide, he had that crate on his back. He has overloaded the level of what his joint can handle. So he's not allowing for that regeneration to occur. So if you were day in and day out, let's say, constantly lifting a load that is too much for your body, or you're applying some downward force on that joint that it's not used to, too fast, too soon, then we can look at having a breakdown of that joint and not enough regeneration from the degeneration occurring. We also know that our body composition does affect our risk of getting osteoarthritis. And so we encourage people to consider ways to help reduce their body weight. So being overweight and obese is a modifiable risk factor, but recognizing that overweight and obesity is a complex medical condition and that there are many, many factors that influence our body weight, from stress to medications to sleep, to the foods we eat and how much we move our bodies. There are so many factors at play, and it is not by any means an easy feat to modify, but it is something that is in your control to work on to see if you can change your body composition to not affect your joints as much. Physical inactivity. So when you're not physically active, you're not bringing movement to that joint to bring that synovial to that cartilage. So you're not keeping that tissue inside the joint healthy if you are, let's say, sitting all day. And then finally, the last risk factor is if you have muscle weakness. If you don't have strength in your legs, again, you're not going to be able to move, which then doesn't allow for that synovial fluid to circulate in those joints. It's a cascading effect. So looking at ways to increase your muscle strength is definitely a modifiable risk factor. And knowing that strength gains can happen at any point in your life. It does not matter your age. We have lots of evidence saying that people who are physically active in later years can increase their physical activity and increase their muscular strength. Risk factors, however, that are non-modifiable, these are the things you cannot change, are age, sex, and heredity. So we do see that osteoarthritis in that diagram or that graph earlier does increase over our span of age. But we have to remember that if a joint is not functioning properly over a long period of time, then of course that osteoarthritis is going to show up as we age. It's just over time, things like that are going to show up. So we do know that age is a factor. So if you are of an older age, it's quite likely that you do have some level of osteoarthritis. When we look at sex, we're looking at women typically are more likely to have osteoarthritis in their hands, as I said earlier, as well as in their knees. Whereas men, it's a bit more common to see osteoarthritis in hips. So again, we can't modify our sex that we were born with. So of course we can't change that. The last risk factor here that's non-modifiable is heredity. So if anyone, particularly your parents, had osteoarthritis, you definitely have a higher risk of having osteoarthritis yourself. So if you do a little check of your family tree to see who has osteoarthritis, it's possible that it also might show up for you if they have it. But of course, if you know that, then there's a lot of ways that you can work around it, particularly being here in the GLAD program. You're working on strengthening your muscles and getting your joints moving better so that hopefully yours osteoarthritis doesn't become severe. So osteoarthritis, how do we diagnose this? Well, typically the way that diagnosis is happening now is through symptoms. So rather in the past, they may have looked at x-rays to see, what's happening in the joint. But if some people have x-rays and it shows osteoarthritis and they have zero symptoms, is it something to be of concern? Well, not really. It's more that the symptoms are present and what are we going to do about it? So the symptoms are related to a clinical examination. So your physician or a physiotherapist may examine your joint and determine how well it's moving and is it in a dysfunctional way or not. Then your symptoms are very important. So what sort of pain are you experiencing? Any other sort of clicking or stiffness or any of those other symptoms we've talked about already if they show up. And then of course, risk factors. What are the modifiable risk factors that you might have? Potentially maybe you are overweight, or what are the non-modifiable risk factors? So if you have knee pain and you're a woman, those are non-modifiable, but we know that those are the symptoms, as opposed to looking solely at an x-ray for diagnosis. So just so that you're aware, if, for example, you don't get imaging done, it's simply because we're looking at these other 3 core components for diagnosis as opposed to x-ray. And simply because there's a poor link between x-rays and symptoms. So we'd rather look at the symptoms and know that that's what you're experiencing to be able to make that diagnosis. All right, we're ticking along here. Again, at this time point, if you need to take a little break, go ahead and push pause on this video. Take a moment to maybe grab some water or get up and move for a second. That's fine. So the next content that we're going to cover are the symptoms of osteoarthritis. So in general, symptoms will develop slowly. So as noted earlier, we saw that in early 30s, potentially you could have what looks like osteoarthritis on x-ray. So maybe as early back then you have no symptoms, but then the symptoms start to ramp up into your late 40s and into your 50s, and then quite maybe severe into your 60s. You have feelings of instability in the joint, maybe a looseness or giving away. And I find a lot of people talk to me about instability while descending a staircase. They don't feel like they have the control as they go downstairs. You might experience stiffness, as we've discussed already, reduced range of motion, pain on weight bearing, pain at rest, and red, hot, or swollen joints. So there's some inflammation occurring. There's inflammation process going on in that joint. So it shows up as a swollen joint. And common problems. So what sort of things sort of show up? Well, maybe your leisure activities are quite sedentary. Maybe they are a lot more seated. You're not up and moving around anymore. Maybe you were once active in sport and that is something that you no longer feel like you can do. You've got this pain or you've got instability. Physically demanding jobs become very, very challenging to the point of you have to retire or you have to change jobs because it is too demanding on your joints. You may find playing with children or grandchildren being very difficult. As we know, children are whirlwind little tornadoes that swirl around and around, and for you to keep up with that, you equally too have to be nimble on your feet. And going in with that is change of direction. Children are going to change direction quickly and without notice. And so for you, dealing with hip and knee osteoarthritis, you probably have limited ability to change direction quickly. You don't have that sort of quickness in your feet to move you because that knee or hip is not functioning properly. You might also find it difficult to get socks and shoes on. Standing and walking for a long period of time also becomes very problematic. And then the dreaded staircase. So as I've talked about briefly already, is going upstairs and going downstairs becomes very, very challenging. And not to worry, little dangled carrot here. There is an exercise that we do in the GLA Canada program that helps you with stair climbing. So hold tight. You will get that exercise in your first supervised exercise session. And one sort of symptom that isn't really addressed all the time is the symptom of fatigue. So when we think of fatigue, we're thinking of exhaustion, utter exhaustion. And a really good way, a really good tool to assess fatigue is if you're going to bed at night and you get your regular 8 hours of sleep and you wake up in the morning and you feel the exact same. You still have this complete and utter exhaustion. That is fatigue. If you are just tired and go to bed and get your 8 hours of sleep, wake up in the morning and feel refreshed, then that is not fatigue. You were able to solve it, or you were able to sort of deal with that tiredness with sleep. And so when people are dealing with osteoarthritis, the symptom of fatigue can be very, very debilitating. And it's not always, you don't always make that link that that is actually what's happening, as it's related to the condition and disease that you have in your joint. So what causes this fatigue? Well, there really isn't a strong relationship and research right now to say what exactly is causing it, but the current sort of theory around it is related to inflammation. And so we have an inflammatory joint disease that is, wreaking havoc on our immune system to some extent. And so that fatigue could be a result of the fact that you're dealing with excess inflammation in your joints. So what can you do to reduce your fatigue? Well, thinking of things that are going to help energize you. What are the activities that sort of invigorate you? And hopefully what you'll find in the GLAD Canada program is that the exercise might give you a little bit more vitality, a little bit more energy as you go through the exercises. So we just want to recognize that fatigue is definitely a symptom of osteoarthritis, and that it is something that you can sort of work through to try to find ways to bring some more energy back into your day. Alrighty, we're on the home stretch. We're going to do this brief overview of treatment next. And if again you need to take a little bit of a break, go ahead and hit pause on the video, take a moment before we jump into the next and almost final part of this presentation today. We're looking at a brief summary of the treatment for osteoarthritis. So let me orient you here first on this pyramid diagram. We've got the green section, which is at the base of this pyramid, and then it tracks all the way up to the peak of this pyramid. That is education, exercise, and weight control. Then we have the orange section of this pyramid, and it goes from sort of the middle of the pyramid up all the way to the top. And this is pharmacological pain relief aids, other aids to daily living, and passive treatments given by therapists. And then the top part of our pyramid, you can see that prominent red triangle, and the big word there is surgery. So what this pyramid is representing are the different lines of treatment. And so like anything, we need to start at the foundation of this pyramid. What is the foundation but the first line treatment? Is education, exercise, and weight control. So when we look at the first line of treatment, this encompasses all people who have osteoarthritis. We want to give you some education. We want to get you moving and exercising with some targeted exercises for the specific joints. And we also want to help you with some weight control. This is the first step, and this is the GLAD Canada program. So if you're dealing with osteoarthritis, this is the first step of what you need to do to help control your condition. If, for example, the first line of treatment is something that you have tried and you've worked on, but you're still dealing with pain, then potentially you move up into the orange section of the pyramid. And when we move up, we also bring along the base of that pyramid. So it's the first and second line of treatment. So this could be things like medications that you take, may include sort of tensors or supports that you wear on your joint, or it might be going in and having some forms of treatment with a therapist. Some of you might need that. So the level first and second line of treatment might be for this mild to moderate determination of osteoarthritis. Some of you may need both first and second line of treatment. Some of you on watching this video may even be doing both first and second line of treatment. And then as we head to the top of this pyramid, we are looking at the red section. And so layering on the red section of surgery is first and second and third line of treatment. So those people who have severe osteoarthritis in their joint may potentially be candidates for surgery. But as you can see that it is few people that actually need surgery for their osteoarthritis. So as you can imagine, if you can reflect on your situation and how things are going in your body, where do you fall on this treatment pyramid? I can all imagine that all of you are in the green section because you're all here taking this course. However, where else do you need to go with your treatment? Potentially first line might be all that you need. Maybe you need to add second, and maybe in discussion with your physician, you might need the third. But we all know that we need to start somewhere, and so we start with that first line of treatment. And so how perfect was this? This leads into the GLAD program. We are doing education. We are going to have supervised exercise, and then we're going to help you with weight control. This is all the GLAD program. And I should say the GLAD program actually comes out of Denmark. So GLAD actually stands for GoodLife Osteoarthritis Denmark. So the GLAD. And so now that it's in Canada, we've tacked on Canada at the bottom of the program. So it is a program that's come out of Denmark, and they've had some amazing results over the years. They've done research and are seeing really great benefit for people who have osteoarthritis as they go through the program. So then moving into our second line of treatment, these are additional treatments, potentially your medications. So we have our NSAIDs like Voltaren, ibuprofen, Motrin, Advil, and or naproxen. Then we have our acetaminophen like the Tylenol. Potentially some of you on this video may have had a corticosteroid injection at some junction, or have had one or two or things like that. There's also medications such as the visco supplements and stem cell. Other medications or over-the-counter ones would be things like glucosamine as well. And so when we look at this sort of list of second line treatment, it is very important that you speak with your physician about your medications. If they are things that you haven't had a discussion about, it's something you might want to talk with them about. Ideally, we would want to try to limit the amount that you need to take. And we know that the NSAIDs, the anti-inflammatory NSAIDs, are probably the most recommended compared to acetaminophen. So that's why it's number one on the list, is the NSAIDs typically are the ones that are recommended for osteoarthritis. Again, these are important conversations for you to have with your physician and or pharmacist to find the right kind of mix for the second line of treatment. And then the visco supplements and the stem cell and the glucosamine. The first two, the visco and stem cell, there is limited evidence around their benefit or their efficacy in osteoarthritis, so typically not used, but still out there. As well as the glucosamine, there is definitely no evidence to show that it affects our pain levels or cartilage structure compared to a placebo or sugar pills. So there isn't evidence really to support that medication or that over-the-counter medication as well. So second line. Also in our second line of treatment, as you can imagine, are different sort of aids. So we've got foot supports such as orthotics. You might have a brace, something to help mobilize your joints. You might use walking poles or a cane or a walker, so anything to help you move more. You've got your walking aids. Might be for swollen joints, you would use a hot and cold pack. You may have TENS, which is the electrical stimulation at a physio clinic. You might also have acupuncture. So there's all these other sort of second line of treatments. But if you think of the mechanism at play when we want to bring fluid to the joint to nourish that cartilage, none of these things do that. These things just support you while you are experiencing discomfort and pain. Whereas when we look at the first line of treatment, we know that exercise is going to help bring nutrients to that tissue that's potentially faltering. So again, thinking about how we're approaching our treatment for our osteoarthritis, let's sort of zone in and do the things that make the biggest difference, and then maybe use some of these other aids if we need to, but knowing that they're kind of like a Band-Aid approach. We're not getting kind of to the root of the issue, right? We're just sort of trying to support ourselves. So don't get me wrong, all of these things are great. If you need them, please use them. But again, that first line of treatment is crucial because it is actually targeted effort towards that joint and what it needs. And then moving into the third line of treatment, looking at surgery. Probably a while ago, arthroscopic surgery or house cleaning was very common. However, now it is not the sort of gold standard of treatment by any means. So we're not looking at arthroscopic surgery as a treatment for osteoarthritis. There's actually been studies comparing the use of this surgery against people who did not have the surgery, and there is no difference. So they're really not surgeons aren't necessarily doing this sort of procedure anymore for people with osteoarthritis, and it's really not the recommended way to go about it anymore. However, what is probably more common for surgery would be for total joint replacement. So you would get an artificial knee or an artificial hip that's made from metal and plastic. So this is for the severe stages of osteoarthritis. So that's when you've gone through the first line of treatment, the second line of treatment, and nothing is helping you any further. So we would look at a total joint replacement. Again, this is conversations with your physician about this. And so when people do go and have these surgeries, 80 to 90% experience at least some pain relief. So there is some evidence to show that it does help with pain. However, it's not a magic bullet. That number is not 100%. So it isn't necessarily going to relieve everything and all things with your osteoarthritis. So just having that awareness that it's not that magic bullet. So that first line of treatment is all about that exercise therapy. And we can see here on this diagram, effect size on the vertical means the benefit. So the higher the number, the more benefit. And on the horizontal, we look at the different types of treatment. So we have education, we have weight loss, we have exercise therapy, and then two medications there, the NSAIDs and the paracetamol. So if we look here, you can clearly see that the exercise therapy has a greater effect size, both for pain and for function. So we definitely want to use exercise as a tool to treat our osteoarthritis. So with the GLAD program, we're really looking at helping you reduce the level of pain that you experience. We want you to have better function so that joint is moving like it should be. We also are looking at an improved quality of life and hopefully reducing the amount of medications and painkillers that you need to take. So at our next education session, in session 2, we'll be talking a little bit more detail into the treatments that are available, more so than what we talked in this presentation. We're going to talk about exercise. So why, how, and how do we manage this pain? As well as talking about ways to self-manage, so activities of daily living and coping as well. And so thank you so much for your attention listening to this presentation today. We are more than happy to answer any of your questions. So do speak to your exercise specialist who is facilitating your GLAD group if you do have any questions. I encourage you to jot them down right now on a piece of paper, and hopefully you can take them to your exercise specialist and ask those questions and get the answers that you need. Again, thank you so much for being here and going through this education session number 1 for GLAD Canada Hip and Knee program. My name is Lisa Workman. and I'm one of the exercise specialists at the Edmonton Southside Primary Care Network.